Hello everyone. In this class, we'll try to learn about renal blood flow. The learning objectives of this class would be to appreciate the arrangement of arterial supply and venous drainage of kidney, understand the process of formation of peritubular capillaries and vasa recta in nephrons, clarify why kidney is susceptible to early hypoxic damage in shock, to know the basic principles of measurement of renal blood flow, to describe the mechanism of regulation of renal blood flow and list the hormones that cause renal vasoconstriction and vasodilatation. Kidney receives about 23.5% of the cardiac output through, uh, though they constitute less than 0.5% of the total body weight. Blood flow to the kidneys is about 1260 ml per minute or 420 ml per 100 grams of tissue per minute. Thus, blood flow per unit weight of kidney tissue is much more in comparison to other organs. However, there is a difference in the regional distribution of renal blood flow, with the flow being maximum in cortex and minimum in medulla. However, blood flow in the cortex is about 5 ml per minute per gram of tissue in medulla and about 0.5 ml per minute per gram of tissue. The low blood flow in medulla helps to maintain hyperosmolarity in the medullary interstitium that plays an important role in countercurrent mechanism of urine concentration. You can see uh, differential blood supply to the cortex and the medulla. The medulla receives less blood supply compared to the cortex. Each kidney is supplied by a single renal artery that originates from aorta. The renal artery branches from anterior and posterior divisions that form total 5 segmental arteries. Each segmental artery branches into interlobar artery, which is in successive divisions from arcuate artery, interlobar artery, that is, which is present in the cortex, which forms the cortical radial artery, and afferent arteriole. Afferent arteriole gives rise glomerular capillary network, that is glomerulus, which finally drains into efferent arteriole. Efferent arterioles lead to second capillary network, which is formed around the renal tubules. Hence, they're called as peritubular capillaries. The venous system of kidney parallels to the arterial system. Efferent arterioles from peritubular capillaries or vasa recta, which drain into interlobar veins. Subsequent sequence of drainage is arcuate veins, interlobar veins, segmental veins, and finally the renal vein. In the medulla of kidney, blood supply is derived from efferent arteriole of juxtamedullary glomeruli. These efferent arterioles in juxtaglomerular nephrons, in addition to formation of peritubular capillaries, form an extra set of capillaries which are called as vasa recta. Vasa recta are straight and long capillaries that run deep into the medulla. Thus, there are descending and ascending limbs of vasa recta that remain in close contact with each other. This arrangement of vasa recta helps to uh, function as a counter exchanger in the urine concentrating mechanism by exchanging substances between blood flowing into and out of the medulla. The blood from inner medulla returns to the cortex in the ascending limb of vasa recta. Functions of vasa recta: it provides oxygen and nutrients to the nephron segments. It delivers substances to the nephron for secretion into tubular lumen. It serves as a pathway for return of reabsorbed water and solids to the circulatory system. It participates in concentration as a countercurrent exchange and in dilution of urine. So these are the blood supply uh, to the uh, to the nephron, mainly through the arcuate artery, then they forms afferent arterioles, then glomerulus, then it is drained by the efferent vessels, and then they are going to form the vasa recta. So then ultimately they are going to form the arcuate veins, and then they are going to drain into the interlobular vein. You can see the renal artery gives the segmental arteries, then they form interlobar arteries, then arcuate arteries, then the interlobular arteries, afferent arterioles forms the glomerular capillaries, which are going to form efferent arterioles. They are going to form peritubular capillaries or vasa recta. Then these are going to drain into the interlobular veins, arcuate veins, interlobar veins, segmental veins. Then they're going to form renal vein. Importance of renal blood flow. It supplies oxygen, nutrients, hormones that control kidney functions, delivers metabolites and waste products to the kidney for their excretion in the urine. It controls concentration and dilution of the urine. It influences solute and water absorption from kidney. It determines the GFR, that is, the renal blood flow is the main determinant of glomerular filtration rate. As kidney maintain blood volume, blood pressure, and ionic composition of the body fluids, alteration in renal blood flow leads to serious consequences. Adequate renal blood flow is essential for these homeostatic functions. Therefore, in hemorrhagic shock, one of the primary objectives of treatment is to maintain renal blood flow so that azotemia does not develop and excretion of waste materials in urine continue to occur. Oxygen consumption of kidney. Kidneys are metabolically active organs. Therefore, the oxygen consumption by kidney per unit tissue is more than other metabolically active organs like liver. In kidney it is around 6 ml per 100 gram of tissue, and in liver it is 2 ml per 100 gram of tissue per minute, and in brain it is around 3.3 ml per 100 gram of tissue per minute. A greater blood flow to the kidneys, that is 24% of the cardiac output, ensures higher oxygen supply to the organs. However, oxygen supply to the kidneys more than they normally need. The oxygen consumption by kidney as a whole is much less, which is about 18 ml per minute in comparison to 52 ml per minute for liver, 50 ml per minute for skeletal muscles, 45 ml per minute for brain, and 30 ml per minute for heart. Therefore, artery-venous difference across the kidney is considerably less than other organs. This ensures adequate oxygen reserve for kidney in various physiological conditions. Nevertheless, in spite of adequate oxygen supply to the kidney, damage to the renal tissue occurs in hypoxic conditions such as in shock. The vascular arrangement in the most of the kidney tissue permits shunting of the greater fraction of oxygen in the arterial blood to the venous blood before blood passes through these capillaries. Therefore, in spite of adequate oxygen supply to the kidney, oxygenation of renal tissue is not high as expected, and hence kidney is susceptible to hypoxic damage in shock. How to measure the renal blood flow? The renal blood flow can be measured by Fick's principle. Also, electromagnetic flow meter and other flow meters measures RBF. With application of Fick's principle, renal blood flow is detected by measuring the amount given substance is taken up by the organ per unit time and dividing this value with the arteriovenous difference of the substance across the organ, that is kidney. Kidney filters blood to form urine. Therefore, renal blood flow equals to the amount of substance excreted per unit time divided by its renal arteriovenous difference. The substances used for measurement of renal blood flow should have the following properties. The substance should be measurable in the arterial and venous blood, should not be metabolized, should not be stored, should not be produced by the kidney, and by itself it should not affect the blood flow, renal blood flow. Usually the substance used for renal blood flow measurement is para-amino hippuric acid, as it possesses all the above mentioned properties. The renal blood flow is measured by using the appropriate formula that uses the renal plasma flow and hematocrit. Renal blood flow is renal plasma flow divided by 1 minus hematocrit. So as you can see the formula, renal blood flow is equal to renal plasma flow. It will be divided by 1 by hematocrit. Thus the renal plasma flow and hematocrit are thus the first renal plasma flow and hematocrit are estimated. Then uh, hematocrit is usually determined by centrifuging a blood sample, and renal plasma flow is measured by clearance of pH infused intravenously. Measurement of renal plasma flow. Renal plasma flow is measured by injecting paramonohippuric acid, then determining the concentration of pH in the urine and plasma. The extraction ratio, that is the arterial concentration minus renal venous concentration divided by arterial concentration for pH is high. That is the extraction ratio for pH is high because pH is filtered from glomerulus and secreted by tubular cells. Following its injection, 90% of the pH in the arterial blood is removed in the kidney through its single circulation. Therefore, usually renal plasma flow is calculated by dividing the amount of pH in urine by plasma level in pH. Peripheral venous plasma is used as a concentration of pH in peripheral plasma is essentially identical to that of arterial plasma reaching the kidney. The value obtained is called as effective renal plasma flow. To emphasize that, the level in the renal venous flow, the venous plasma is not measured. In human being, the ERPF is about 625 ml per minute in average. So this is how the formula by which the effective renal plasma is going to be determined utilizing urine plasma pH concentration, the volume of the urine, and plasma pH concentration. For example, when concentration of pH in urine is 12.4 milligrams per ml, urine flow is about 1 ml per minute, and concentration of pH is in the plasma is 0.02 milligrams per ml. The effective renal plasma flow is calculated as 620 ml per minute. Then effective plasma renal plasma is converted actual renal plasma flow by the following method. As the average pH extraction is around 0.9, so the actual renal plasma it becomes 689 ml per minute. And if you know the hematocrit, which is around 47%, if at all, the renal blood flow will be around 1300 ml per minute according to the calculation. Thus, the renal blood flow as calculated from the above is around 1300 ml per minute. Regulation of renal blood flow. The neural factors, the sympathetic control. Stimulation of renal sympathetic fibers causes vasoconstriction that decrease the renal blood flow. Therefore, conditions that activate renal sympathetic fibers such as hemorrhage, cold, pain, exercise, anesthesia decrease blood flow to the kidney. Though sympathetic stimulation in these stressful situations aims at diverting blood from splanchnic circulation to the vital organs, stimulation for longer duration as occurs in hypovolemic shock causes renal shutdown and azotemia. Sympathetic stimulation also increases renin secretion from JJ cells and that activates renin-angiotensin system. Formation of angiotensin II causes renal vasoconstriction and further decreases blood flow. Fortunately, angiotensin II and sympathetic stimulation to kidneys stimulate the production of local prostaglandins, that is prostaglandin E2 and I2, that produces vasodilatation and oppose the vasoconstriction effects. Therefore, sympathetic stimulation, unless intense and long-standing, cannot ordinarily compromise renal functions. Hormonal factors, circulating catecholamines and other vasoactive peptides like angiotensin II cause renal vasoconstriction. However, dopamine in high dose cause renal vasodilatation. Therefore, dopamine is preferred for the treatment of cardiogenic shock as its systemic effect increases blood pressure and its renal vasodilatation effects maintains renal perfusion. Local factors locally produce metabolites like chemicals like carbon dioxide and prostaglandins cause renal vasodilatation and maintain renal blood flow. Though adenosine is a potent vasodilator in coronary and cerebral circulation, it causes constriction in the renal vascular bed. These are some of the vasoconstrictor and vasodilators in the renal bed. Vasoconstrictors are epinephrine, norepinephrine, angiotensin II, adenosine, uh, which acts through the A1 receptors, endothelin, vasopressin, and thromboxane A2. Whereas vasodilators are atrial natriuretic uh, factor, dopamine, histamine, kinins, endothelial derived uh, factor, prostaglandin E2, prostaglandin I2, prostacyclins, acetylcholine, and adenosine, which are acting through A2 receptors, are some of the vasodilators. Blood flow to the kidney is maintained at a relatively constant level despite the change in systemic pressure range, that is between 80 mm Hg and 180 mm Hg, and this is called autoregulation of the renal blood flow. Myogenic mechanism of autoregulation. The renal autoregulatory mechanism is an intrinsic phenomena as it is also observed in isolated and denervated kidney. However, it is absent when renal vascular smooth muscle is paralyzed by drug administration. This indicates that autoregulation is mainly due to the direct contractile response of renal smooth muscle to stretch. So this is called as a myogenic mechanism of autoregulation. This process increased pressure in the blood vessel causes stretch of the vessel wall that opens the cation channel resulting in depolarization, and this leads to voltage dependent opening of calcium channel causing calcium influx. Increased intercellular calcium causes vasoconstriction, and opposite changes occurs when blood pressure decreases. This diagram showing the autoregulatory mechanism which operates in the range of the systolic pressure between 80 and 180 mm of Hg. Metabolic mechanism. The local metabolic mechanism also contributes to autoregulation of blood flow in which nitric oxide, prostaglandins, adenosine and other metabolites produced in the tissue influence blood flow. And it is also regulated by glomerulotubular feedback mechanism. The glomerulotubular feedback mechanism also plays important role in autoregulation of the blood flow in which the composition and flow of tubular fluid determine the renal blood flow and glomerular filtration. This is in brief about the renal blood flow and its regulation. Thank you.